webinar from Vikas. Today's topic is diabetic foot and its complications. I am Pavitra, your host for the webinar. Before we start, let me give you a quick introduction about Vikas. Vikas is a not-for-profit organization working for senior citizens. We currently provide 4 main services: health and wellness, legal advice, financial advisory, and an online community. Please check out more about us on our website www.vikas.org, and you'll also get more information there about all the services that we provide. If you're not a registered member, please do join us to get information on more such events that we will be conducting and also about our other services. I request all of you to be on mute while the doctor is talking, and you can ask your questions in the chat window and we will get back to it. Let me introduce a speaker for today. Dr. Narendra Reddy did his MBBS from the Kempegowda Institute of Medical Services, Bengaluru, MS in General Surgery from the Bangalore Medical College, and his fellowship in Vascular and Endovascular Surgery from Manipal University. After gaining proficiency in the entire spectrum of general surgery, Dr. Narendra Reddy has been concentrating throughout his career on renal surgeries, laparoscopic and endovascular surgeries. He has presented papers in both the state as well as national level conferences. With over 25 years of experience, Dr. Narendra Reddy has acquired immense knowledge and experience in handling even the most complicated laparoscopic and vascular surgeries. To add, he has a vast experience in diabetic foot management and podiatry. Thank you, Dr. Reddy, for joining us today. Over to you.
Hello and welcome everyone to this session.
Your volume is not, we can't hear you.
Now, can you hear me? Am I audible now?
Yes, sir, you are audible.
Okay.
Your volume is still not able to hear you, Dr. Reddy.
My volume is highest.
Sir, it's okay, sir. We are able to hear you.
Sorry, yes, continue.
We can hear you.
Okay. Okay. Thank you very much, and welcome to this session. So,
Good evening.
Hello, sir. Good evening. Good evening. So, the month of November has been declared by the WHO as a Diabetes Awareness Month. So, I'm sure there will be other speakers talking about other aspects of diabetes. But in this session, I will be talking more about the complications of diabetes, more about the diabetic foot complications. As you know that you might be seeing a lot of patients with ulcers on their foot, those who are diabetic and those ulcers are not healing. So I will be discussing more about the diabetic foot complications of diabetes. So this is one of my interests in vascular surgery is diabetic foot and its complications. I deal with this almost on a daily basis. So I would like to share my experiences with you. So I will be doing a short presentation to you. And if you have any questions, feel free to raise your hand, or you can also interrupt me during my presentation and you can ask me questions. I am conversant in English, Hindi, Kannada, Telugu, and in Tamil. So please don't hesitate to ask me questions in these languages. If I can, I will try and answer you in these languages. So I will be starting my presentation now. So it is always better to prevent a complication than try and cure these complications. So my topic that I chose for today is about diabetic foot and its complications of diabetes. So I'm a vascular surgeon working for Manipal hospitals, and there are no disclosures to be made. So Leonardo da Vinci once said that the human foot is a masterpiece of engineering and it is truly a work of art. So we get a lot of patients who come with issues concerning the leg. So when somebody comes to us with leg pains, there are many reasons why they come with leg pain. So the most common reason would be probably the vascular pain, where there is a peripheral vascular disease, that is, the arteries of the legs would have got blocked. Some patients will have varicose veins, and again we get a lot of clots in the legs called as deep vein thrombosis. Again, we see what is called as a neurological pains, that is, when the nerves running down their back get pinched by the bones, by the backbones, what is called as a lumbosacral compressions. And then we get diabetic neuropathy, where the nerves where the peripheral nerves, the nerves in the leg, in diabetic patient, they cease to work, they don't work because of metabolic complications. So we see those kind of patients quite often. Also, we see sciatica, that is back pain, where the nerve running down the back of the leg gets pinched. So that is sciatica, that's a pain that runs down the leg. Then again, as we age, so we get pains in our joints, that is arthritis. Again, as we age, we get sprains in our muscles and we get fractures that are sometimes not known. Other common complications of diabetic feet are cellulitis. Cellulitis are just infections of the subcutaneous, of the tissues below the skin and within the muscle. So that's an infection. You can see on the right-hand side screen that infection, cellulitis. And then we get ulcers of the foot, again, probably because of diabetes. So it is, as specialists, it is our job to differentiate these kind of pains and to treat them accordingly and to guide those patients as to which is the best course of treatment. So a brief history of diabetes. So the incidence of diabetes is on the rise worldwide, probably because of dietary habits and also because of sedentary lifestyles. So unfortunately, India is now considered as a diabetic capital of the world. So we have approximately now about 120 to 130 million diabetics in this country. You can imagine the number of undiagnosed patients living in the rural areas who don't have access to proper health care. And in India itself, the southern part of this country, that is Tamil Nadu, Kerala and Karnataka, as well as Gujarat, have a very high incidence of diabetes in patients who are in persons who are above 50 years. Approximately in the southern part of India, some studies have shown that 15 to 16% of the adult population are diabetic or pre-diabetic. So it is going to be a huge health burden for this country, especially those people who have not covered through insurance and to have to undergo treatment for diabetes and its antecedent complications that come with the diabetes. So for a country like ours, it's going to be a huge health burden. So the earlier we catch up with diabetes and its treatment and prevent complications, the better for this country. Then again, a little bit of statistics. In 2015, there were estimated 415 million people across the world. Right now, it's approximately nearing 500 million people with diabetes. That is almost 1 in 10 or 1 in 12 people living in this world. So there's going to be a very high disease burden for the governments and for healthcare providers. Again, coming to diabetes. So diabetes is not a disease that affects any one system in the body. It is a universal disease that will affect head to toe. For various reasons, it affects different parts of the body. So starting from the brain. So diabetic patients are more prone to brain disorders such as strokes, dementias, and then they have these cognitive impairments. Eyes. So in the eyes, long-term diabetic might get a retinopathy, again because of excess of blood vessel buildup in the eye. So that might lead to sudden blindness. They're more prone to cataracts and glaucoma, that is the pressure within the eyeball, so it increases in diabetic patients. People with diabetes are more prone to developing heart attacks, blocks in their hearts, and heart failures. Also patients with diabetes, they're more prone to developing kidney failures. and they leak proteins and sugars in their urine, leading to microalbuminemia, less proteins in the body, as well as renal failures. And coming to the legs, so diabetic patients are very prone to developing blocks in the arteries of their legs. So this is basically because of buildup of atherosclerosis, buildup of a fibrofatty deposit in their arteries, which are very prone to damage. And then a plaque builds up within the artery, and usually the arteries get closed. Most often we see in the arteries that run below the knee. Also, we see a lot of patients who come with arteries above the knee and in the abdominal arteries. So these blockages, if they're not detected early or treated, can lead to ulcers, that is wounds that don't heal, gangrene, and unfortunately leading to major or minor amputations. And again, long-term diabetics, so they develop what is called as a neuropathy. Neuropathy is basically what it means is you don't feel the earth, you don't feel the floor when you're walking. We get a lot of patients who come and say when they're walking, they don't feel the earth, they feel they're walking on air. Some people say they would have lost their slippers, they don't even realize that they have lost their slippers when they're walking. So that is a neuropathy. This again is very peculiar to diabetes because of impaired metabolism of vitamins, especially the B complex vitamins, their impaired metabolism and lack of blood supply going on to the nerves, those nerves get damaged. So you should be told to those patients that once a patient reaches this stage of neuropathy, it is very difficult to reverse neuropathy. It's almost virtually impossible to reverse neuropathy. From this stage onwards, patient should be cautioned about prevention of complications or even getting into complications, and they should take care that they would not get hurt or injured or things like that. So coming now to the topic of discussion for today, that is diabetic foot and its ulcers of the diabetic foot. So it is well known that there's a triad of factors that lead to ulceration of diabetic foot. One is a neuropathy, which I just talked to you about, and second is ischemia. Ischemia simply means less blood flow coming down to the arteries, from the arteries to the foot. Because of atherosclerotic buildup, because of the fibrofatty plaque buildup, it's very similar to what happens in the heart. When the arteries of the heart gets blocked, you get a heart attack. Similarly, when the arteries of the legs get blocked because of atherosclerosis, we get leg attacks. So this is a very slow process. So that is ischemia. These two factors can lead to infection. Infection again is because of the less compromised immune status. By nature, a diabetic patient has got low resistance to infection and very difficult to fight infections that occur in the body. So superadded infection occurs very early in diabetes, again because of high blood sugars, because of low resistance to infection. Added to that, trivial traumas or major traumas can make it worse. And how do these problems start? How do the diabetic ulcers or the diabetic wounds start with diabetic patients? Usually they're insidious. They would have lasted for months together or weeks together before someone else notices this problem, or the patient themselves see this problem. We get a lot of patients who come to us because it begins to smell. It begins to form ulcerations. They would not have noticed it. They would not be inspecting their legs, or the attenders bring the patients to the hospital because of the foul smell coming from the legs and from the wounds of the legs. So people have to look out and watch out for these problems. So there are three areas where this problem starts. One is the neuropathy, one is the lack of blood supply, that is ischemia. Third is infections that lead to complications of these things. So let me start with neuropathy, which is a more of a scientific topic. So why does neuropathy occur? Neuropathy again is just because of altered metabolism that occurs in diabetic patients. Like I told you, the B complex vitamins are differently metabolized in a diabetic patient. Then we get three kinds of neuropathies. One is what is called the sensory neuropathy, that is the sensations of pain, touch, pressure, burning sensation, they're lost. People don't feel the earth. So even when they hurt themselves or they injure themselves, even there is a wound, they don't actually feel the pain. In any normal individual, they would be shouting and jumping with pain. But we have seen diabetic patients with ghastly wounds that they don't even seem to notice those wounds. So those are the sensory neuropathies that occur and then lead to these problems. And then you have the motor neuropathy, where there are usually problems with the bones and with the tendons and with the ligaments that occur with diabetes. What we call scientifically as the Charcot's foot, where again, because of altered metabolism, the bones of the small bones, there are multiple small bones in the foot, just like in the hand. They get dislocated, they get disentangled from each other, and also the nerves and also the tendons and ligaments that attach these bones to the muscles, they get detached. So you might have seen a lot of patients with diabetes with a deformed foot. You'll be wondering why their foot is deformed as compared to now. But again, this is because of neuropathy. In neuropathy, what happens is the different groups of muscle that act. One is to extend, one is to flex. So they act differently. So different groups of muscles start pulling in different directions. Therefore, the bones that are there in the foot, they get dislocated, they get disjointed from each other. And then that lead to fractures, that lead to infections and things like that. So because of the sensory neuropathy and the motor neuropathy, we commonly see these kind of complications. So what you see in these images are what are called as corns and callosities. What in Kannada and Telugu they call as anekon. So these are the starting stages of diabetic foot. So once a patient comes with this, so this occurs mostly because of improper pressure placement. So there are actually pressure points in the foot, and because of the dislocation or because of the deformity of the foot, also because of lack of sensation, sometimes walking barefoot itself. So we Indians are basically barefoot walkers. That should be discouraged. We should be encouraged to walk even at home, inside the house, with slippers. So that gives a lot of protection. So since we're barefoot walkers, we use probably hard footwear, and we get different pressure points in the foot because of diabetes. We start developing these kind of corns and callosities. So they should be picked up early. Once these are picked up, go to a proper podiatrician or a general surgeon or someone who deals with this, get them treated, get them paired, get them shaved off. If they're late stages, if they're very early stages, you can just give it a good wash with soap and water, give it a good brushing with a soft loofah or a soft brush for 10-15 days, and soak your feet in warm water, not hot water, warm water. Put some salt in that water and then give it a good brushing, the soft brush. Try it for 10 to 15 days. Most of these corns and callosities will disappear. There is no need to apply any salicylic acid or any corn caps on those cuttings, because those tend to burn the skin and it can get worse, it can get infected. So simple home remedies should be enough to treat these kind of corns and callosities. Again, once these corns and callosities occur, so the next step, if they're not treated properly, so they become ulcerated, they become a wound. So like I told you, 15 to 20% of patients with diabetes will develop a diabetic foot ulcers, wounds in the leg over their lifetime. Also remember that when we amputate, it is not a happy surgery, it's not a good surgery to do. God forbid if a patient comes for amputation of diabetic foot, 85% or preceded, they would have had a foot ulcer in the past, in the last few months or years, that have not healed, or rather have not been looked after properly. So treat those foot ulcers and this one very promptly. So how does ulcer form after a callosity? So on the right hand side of the screen, you can see a cartoon image of a callus formation. A callus formation is nothing but thickening of the skin of the dermis and the epidermis, and then the skin doesn't fall away. So its skin grows over each other. Because the skin is so thick, a little bit of blood clot occurs underneath the skin, and that is what is called as a subcutaneous hemorrhage. Again, you can see in this diagram the deformed toe. It is what is called as clawing, like a clawed beak. So this is the clawing. Again, it's because of the neuropathy, because of the autonomic and the motor neuropathy, the foot becomes like this. And whenever you put your foot on the floor, you get improper some pressure points. So you get pressure points on improper areas, and then you get this kind of callosity. So once you get a callosity, the skin breaks down. So once the skin breaks down, it forms an ulcer and forms a skin is the best covering for the body. So that's it. Once the skin breaks down, that forms a passage for bacteria and for dirt and for dust and dirt to enter into the thing. So once it becomes deep-seated infection, it can affect the bone. Once the bones of the foot are affected, it is virtually impossible to treat it other than a surgery or an amputation. It becomes literally impossible. You might give antibiotics for months on end, but those infections are very difficult to treat. So that becomes an osteomyelitis. Osteomyelitis is infection of the bones, soft tissue on the bones. So these are some of the images that I have taken of patients. On the left top screen, you can see cellulitis. Cellulitis is infection of the skin and the soft tissue of the foot. On the right hand top, you can see the deformity of the foot. These are very common deformities we see in advanced diabetes. And then bottom two, you can see infections and gangrene. These are, again, you can see the deformities of the toes. You can see the clawing of those toes, how they become in advanced diabetes. So those lead to gangrene and infections. So how do infections occur? Infections are usually polymicrobial. There is more than one bacteria that affect. Sometimes the bacteria on top of the skin itself can affect the diabetic, or bacteria from elsewhere with trivial trauma, trivial injuries. So again, infections can be divided into limb-threatening or non-limb-threatening infections. They do occur because of a blunted neurogenic inflammatory response. The inflammatory response of the white blood cells in a diabetic patient is impaired. We do not have the capacity to fight infections. So the immune response is very, very muted. It's very less. And again, when you get a patient with high blood sugars, about 250, 300, and you don't find a source for that, or in spite of giving anti-diabetic measures or insulin, still then look for the infections. Look for infections in the foot or elsewhere in the body. So that could be a source of infection. That is why the blood sugars are going up. Sorry to put this figure. It's a bit ghastly, but this is how a lot of complications end up with. Now, infections is over. Now coming to ischemia. Ischemia is nothing but reduced blood supply to the legs. So nature has provided only one artery from the heart going down into the legs till the knee. Below the knee, it divides into three smaller arteries. So we have only one artery supplying the legs. So what happens in ischemia is there is what is called as a macrocirculatory failure and a microcirculatory failure. Macrocirculatory failure affects the bigger arteries of the legs. So then this occurs because of atherosclerotic fibrofatty deposition. It gets complicated in patients who have poor lifestyle habits, especially smokers. Smoking and diabetics are a double-edged sword. So you see a lot of diabetics who are smokers who end up with these kind of problems. Poor lifestyle, who don't walk, who don't exercise regularly, who have got a poor glycemic index. So these are the people who end up with the fibrofatty deposition in their tissues. So, and atherosclerosis, once it develops, and it usually develops earlier on in diabetes. It is simply an inflammation or a small nidus in the artery on which the plaque grows. It keeps on growing month on month, year on year, till such time where it completely blocks or nearly completely blocks the artery. So this is the end stage of the atherosclerotic disease. So there is a bouquet of syndromes described in diabetic foot, right from the ulcers of the foot, neuropathy, critical ischemia, gangrene, leading to infection, cellulitis. So these are the bouquet. And also there is what is a terminology called as a Charcot's foot. So the minute we see a patient and see a deformed foot, we label it as a Charcot's foot. And we advise those patients about footwear, foot care, how to take care of the foot, and how not to get. I'll be talking about it briefly in this topic itself. So I have spoken about the gruesome complications of diabetic foot. Now, what do we do to prevent foot infections or foot complications of diabetes? So periodic surveillance, get your foot examined by a podiatrician or a surgeon or a physician or a vascular surgeon on a regular basis. You will be going as a diabetic, I'm sure you'll be going every 6 months to meet your diabetologist. Get them to examine your legs. It's as important as examining any other organ. So a good surveillance can lead to reduced amputation rates. So it is not a one-person intervention. So you have to start with your endocrinologist, with your diabetologist, and then escalate it to a surgeon, an orthopedic surgeon, a vascular surgeon like myself, a podiatrician, and wound care specialist. So the best prevention would be by your primary care physician, your first contact physician. The person you are seeing for your diabetes is the best person to diagnose early complications, and then if he or she can't manage it, to refer to a person who is an expert in this. So let's start about food care recommendations and how to take care of your food. So it is highly recommended that every diabetic should undergo an annual comprehensive food examination. That is, go to your diabetologist or go to your primary care physician, get them to examine the foot in addition to the other systems like kidneys, the heart, and the eyes. So it's a very simple examination. It can be done in just a few minutes, a foot examination. First of all, look at the foot. See if there is any redness, see if there is any deformity, see if there is any nail bed infections. Make sure that you inspect the pulses of the foot. That is, in the front of the foot, there is one artery running, and the side, left-hand side, I mean, on the inner side of the foot, there is one artery running. Just put your finger on these two arteries and check if the pulses are good. And then we have other things such as a pressure monitoring. So we have a monofilament fiber that takes a weight of 10 grams. So on the foot pad, we put the pressure, the 10 milligram microfiber into various points and look for sensation. We ask the patient if they are able to feel the sensation after pressing these. And then we use the vibration. We use a tuning fork of 125 hertz. We put the tuning fork on various parts of the foot and the leg and ask the patients whether they're able to recognize some vibration sensation. That gives us an indication of whether there is a neuropathy that's already started, and we can take the investigations further once a neuropathy has been diagnosed. So the left image on the left is a monofilament fiber that takes a weight of 10 grams. Once we press it, and then we can record the various readings on a computer. Again, the inspection of the skin of the foot. So like I told you, we inspect basically the nails between the toes. So a lot of people have got either a fungal infection or they got small blisters or ulcers between the toes. So usually those are the pressure points, people wearing tight footwear, moisture between the toes, so it's going to lead to infections. And then we look under the metatarsal. Metatarsals are just the bottom of the foot, what is called as a ball of the foot. So we could, and then we look at the heel. Also, we look at the of the curvature of the foot. So also we look at a very, very small examination about the deformities, and also look at the gait, how the patient is able to walk. So if a patient comes to us with a diabetic foot or a callus or an infection, what do? We treat the ulcer very promptly. Before we treat the ulcer, we do other examinations such as the neurological examination and the vascular examination to see if there are any blocks. Ulcers are usually managed by debridement. If there is an infection, the rule of thumb is get the infection taken out promptly. It has to be taken out with antibiotics or clean it up. It is what is called as a debridements, or a fasciotomy, where we open up the skin, remove the dead tissue or the infected tissue. Behind all this comes very strict sugar control. So without proper sugar control, nothing we do works. And these are the recommended footwear. Now, American Diabetic Association now recommends proper footwear. So these are the things you should be looking for. You should have soft sole, at least 1.5 to 2 centimeter. Now, the older MCR kind of footwear are now being given up. Now, people are now the diabetic associations are now recommending silicone rubber insoles. So ideally, this should contain air pockets that gives you the spongy feeling, and avoid hard footwear and avoid footwear that are tight. They have to be one size loose to your feet. So whenever you go to your foot store, one size loose. Ideal recommended footwear is this, and I think a better commercial product would be like Crocs. The ones you see that the children wear, the ones with the front cover with air pocket, air holes in it, and the back strap. So there's ideal footwear. So if you're a diabetic, I recommend you to buy 2 pairs, wear one indoors and one outdoors. So they give a lot of some protection from injury. They also are actually covered in the top and in the front, so that prevents minute injuries. So those are the recommended footwear right now for diabetic patients. And patients should come in indolent, non-healing ulcers that won't heal for 3 to 4 weeks. And the patient has to walk around. Without walking around, they cannot go anywhere. So these are some of the air cash shoes that have come into the market. They've been there for about 20 years now. These kind of shoes have got air pockets where we can pump in air. The weight of the leg is borne on the calf or in the leg. So the flat of the foot doesn't have to touch the ground. So patients can walk around with this. With at least limited walking, they'll be able to do. So with this kind of footwear. Again, when patients come with non-healing ulcers or long-standing ulcers, we have different modalities of treatment. So this one patient I done recently, this is called as a vacuum-assisted dressing. It's a vacuum dressing. This is a portable machine with a battery attached. Patient can carry this and he can go to the bathroom or he can go to the dining room and eat. And this one, so this will be on for about 5 to 7 days continuously. It will keep on sucking out all the fluids and the bad tissues that come out and allows healing to come from inside. So these are the measures that we try to cure ulcers. So that is the surgical part of treating ulcers. So whenever we get ischemia, whenever we get patients who have got arterial blocks, like I told you, there is only one artery that runs down the leg. Nature has provided one artery, but to take care of it. So sometimes these arteries get blocked. So aging itself is a concern. Diabetes, uncontrolled diabetes, high cholesterol, smoking, and poor lifestyle habits. So this can lead to small blocks in their legs that can keep growing and then block the leg entirely. So there are various options to deal with this. First, we have to do an imaging, what is called an ultrasound. And then we do a angiogram, like we do for the heart, we do for the legs angiograms. Identify the blocks and see if it is curable or not curable. And then we can do a bypass surgery. In this case, it is a graft that is used to bypass the diseased artery. Other non-surgical options are available, what is called as an angioplasty. Here we can see the arteries of the leg where there is a balloon that is within the artery and then the balloon gets opened up. And we also got other options, what is called as stenting. So this artery of the leg, which are blocks on the left-hand screen. On the right-hand screen, a stent has been inserted and blood is flowing through. So these are various options that are available to revascularize or improve the blood flow going into the arteries. So what should you do from your side? Get proper workup, go to a proper physician. A healthy diet, lifestyle modifications are very important. Diet, exercise are the best thing, and go for a regular health checkup. So what are the early signs? What do you look for in this to prevent diabetic foot? The most warning sign, the red light would be leg pain in your legs, especially when you're walking. When you start to walk 100 meters, 200 meters, you start getting pain in your legs. You cannot walk any further. And also at a later stage, when you get pain in your legs at rest, at night. So those are warning signs. Go see your physician immediately, get yourself evaluated. Also, patients with non-healing wounds in their legs, wounds that don't heal in spite of treatment, dressings and antibiotics that don't heal for 3 to 4 weeks. Normal wounds should heal within 2 weeks or 3 weeks. If these wounds are not healing, they're extending, they're beginning to smell, get yourself evaluated. Callosities, initial callosities, if they're not very big, I told you the home remedies. Soak your feet in warm water, put some salt, 10 minutes, morning and evening, and then give it a good brush with a soap and a regular soft brush. And then you can apply a moisturizing cream that should take care of most of the callosities. Avoid tight footwear, avoid hard footwear, avoid walking barefoot. Even if you were to go to a temple or a place of worship, please do not go barefoot. Wear socks. No God is going to get angry with you if you wear socks into temples. Avoid stepping on hot surfaces. So you don't feel the heat on hot surfaces. There could be dust and dirt particles that are not seen by you that can poke into your skin. So that's where all these problems start. We get any number of patients who go to pilgrimages, come back with blisters and with diabetic foot, and I tell them walk in the shade, walk with socks on, so that will protect your feet to a large extent whenever you go to places of worship and those kind of things. So when you get unexplained bleeding in the leg without pain, painless bleeding, all of a sudden if you scratch yourself and you get bleeding and you've got, or in the night you're asleep and wake up in the morning you found blood down your leg, that's a warning sign of diabetes, because those arteries don't close so well, they don't heal so well. And swelling, unexplained swelling of your legs, both the legs, go to your physician, get yourself checked out. So these are early warning signs what you look for in diabetes. Then again, it is a statistic that is not a very good statistics. 60% of non-traumatic amputations are occurring in diabetic patients. Across the world, every 20 seconds, a limb is being lost. A limb is being amputated because of uncontrolled diabetes. So this is a very bad image that I had to put up. Imagine a person on a wheelchair who is wheelchair bound, how dependent they are on others, their family members or their friends and relatives to take care of them. Right from taking bath, going to the bathroom, or eating food, or getting up and getting out of the house, they're dependent on their attenders and their caregivers. So important is say no to disability. Disability prevention is very important. And as a vascular surgeon, our motto is save a limb, save a life. Thank you very much. And I can take any questions that I can answer. I'd be glad to answer.
Hello. Can I ask you?
Yes, madam, please go ahead.
If with the neuropathy check, you found that the foot does not have any sensation, the toes
Yes.
do not have any sensation,
Yes.
but there is no ulcer or redness or anything, then what can be done?
So if you say that there is no sensation of the foot, that means you say you don't feel the pain, you don't feel heat, you don't feel the earth when you walk. So that is a stage of neuropathy. So that is a stage of autonomic neuropathy and sensory neuropathy. So unfortunately, medical science is not so advanced as to reverse this. So once a person comes to a stage of neuropathy, it is not reversible. We cannot reverse it. So ideally, you need to control your glycemia. Make sure that your blood sugars are under control. Take a vitamin tablet, a B12 vitamin tablet every day that you can ask your physician. They'll be able to recommend you. Wear proper footwear. Make sure that you don't walk barefoot, and get plenty of exercise and diet. So that's the only recommendation. Unfortunately, neuropathy is not reversible at this present stage. So we only advise people to prevent complications arising from neuropathy.
Thank you.
Thank you.
Mr. Nageshwar Rao, please unmute yourself and ask the question. You raised your
Respected sir,
Yes.
నేను తెలుగులో మిమ్మల్ని అడుగుతా సార్ రెడ్డి గారు.
Okay, sir. చెప్పండి.
అరికాలు మంటలు అప్పుడప్పుడు వస్తాయి, షుగర్ కంట్రోల్లో ఉంటుంది, అన్ని కంట్రోల్లో ఉంటాయి.
అదే సార్.
ఇంకా మిగతా ప్రాబ్లమ్స్ అప్పుడప్పుడు అరికాలు మంటలు ఎందుకు వస్తాయి, వస్తే ఏం చేయాలి?
అదే సార్, అరికాలు మంటలు వస్తే అది వచ్చింది స్టేజ్ ఆఫ్ న్యూరోపతి అంటాము. అంటే మీకు విటమిన్ డెఫిషియన్సీ కూడా ఉండొచ్చు. సో ఎంత దూరం నడుస్తారు మీరు? హౌ ఫార్ యు ఏబుల్ టు వాక్?
I can walk for more than 500 meters or something in the jogging also. I will take the stretching exercise in the morning for all legs and body. Stretching exercise. And some in the gym also I will do some exercise for 15 to 20 minutes. But I am overweight.
Sorry, sir. So మీరు half an hour walk చేసేకైతే, if you're able to walk half an hour without stopping, that means to say you might not be having any problems. మీ arteries లో, నరాల్లో ఏది ప్రాబ్లం ఉండదు. You might not be having any problems in your vasculature. మరి you have gone in for a stage of neuropathy, దానికి మీకు ఉత్తర మంటలు అయ్యేది. I would advise you to take a vitamin B12 capsules. This B complex vitamins తీసుకోండి. మళ్ళీ మీ డయాబెటీస్ డాక్టర్ కూడా కన్సల్ట్ చేయండి సార్. Only footwear important.
Pragam, yeah. Sir, footwear వేసుకుంటా ఇండోర్ అవుట్డోర్ వేసుకుంటాను. ప్రగం M75 వాడతాను.
Sorry, that's good enough. Dan Jyotiki, you can take a B complex vitamin.
B complex every day I will take it, sir. B1, B6, B12 and B complex. That's enough. But this burning is not regular every day. Now and then I will face this problem, especially in the winter season or nights.
Danke, you need to wear proper footwear and take care that you don't get injured and wounds.
I used to take the once in a year foot care also, this examination and all these things. And regularly for 3 months I will go for diabetic checkup and all these things.
Very good. That is I
That's
think
all
you're
right.
on the right path. Yeah, I think you're doing all the right things.
But next God only support.
You don't have to give up, sir. I get some patients who live up to their 90s.
Yes, sir. Thank you very much, sir. I'll be very confident with your answer.
Thank you, sir.
Can I ask, sir?
Yes, sir.
Please go on,
sir. Sir, I'm Sudhir Ranjan Mandal here from Bangalore, sir. Actually, I had this diabetes problem for nearly 20 years now.
Yes, sir.
Finally, after retirement, not much activity. So I had to amputate. There was a sudden increase and there was swelling in the foot and all that.
Yes, sir.
So I had to go for an amputation of the right toe.
Yes, sir.
After that, now they started that wound was there. Rather, the toe was not there. No, so it was open wound. They were cleaning it for a long time, and finally it did not help. Then I went to Ayurveda. They also did for quite some time. Finally, because of the constant rubbing of whatever is developing, then I think it was not getting. I thought that was not getting cured. That the wound was not getting cured.
Yes.
So I left it like that and was trying something else. So finally, it is now healed. Healed in the sense, I think so. It is healed. And there was a oozing in the foot. When I asked, they said it was a lymph secretion, lymph gland secretion or something like that. Anyway, the oozing was there, clear fluid liquid, and there was some smell also. So finally, it got cleared now, almost fully gone. And I've got a clawed foot also. That is also there. But my situation is at one stage at Manipal, they said, you've probably got a bone infection. So then I was trying all methods to remove that also. But finally, I think it is gone, but I'm not sure. I went for second MRI also. Second MRI, and finally said some fluid is there in that particular area. But now it is fully healed. That was some 1.5 months back. Now it's fully healed. But again, the whole of the leg is blackened.
Yeah.
So I don't know what the reason is, and I do not get a satisfying answer.
Okay, sir. So I think you asked me 3 questions. I'll answer one by one to the best of my ability. So if you are having an ulcer that is not healing for over 3 to 4 weeks, so just get an arterial duplex scan, arterial Doppler evaluation. Look at the state of your arteries.
Done, sir.
Yes, so that will give you, by and large, it will give you an estimate of how good your arteries are. So number 2, you've got an MRI scanning done. So MRI scanning in diabetic patients, it will by nature show fluid accumulation within your joints and within your tissue spaces. As long as there is no bony infection, no osteomyelitis, you need not worry about this. So the best thing would be to keep your foot elevated over a pillow at night and live with it. So that's not going to harm you. A little bit of fluid within your tendons, within your muscles, joints is common in diabetes. So that is an MRI finding. It is not going to harm your bones. As far as the third question, the blackish or brownish discoloration of the skin of your foot, it is because of diabetes. So that is what we call as diabetic lipodermatosclerosis. So it is the skin damage that has occurred because of diabetes. So that by and large, it does not reverse. It does not go away. It does not mean that it is gangrene or does not mean it is an ulceration of the skin. You might be seeing a lot of diabetic patients with patches of blackness or black discoloration of their legs and their foot. It is just that it is what is called as diabetic lipodermatosclerosis. The fatty layer of this below the skin skin gets damaged, gets eaten up in diabetes. So that's why they develop a very hard skin like leather that becomes black. That is a natural progression of diabetes. So you need not even worry about that. As long as your wounds have healed, as long as your arterial pulses are okay, your sugar control is okay, your MRI shows there is no bone infection, I don't think you need to worry about it. Just wear proper footwear and you should be okay with it.
Okay. Thank you so much, doctor.
Thank you, sir.
Dr. Reddy.
Raise your hand, please go ahead, sir.
Chennai, Madras. I am a long-term diabetic doctor for nearly 20 years. About 7-8 years ago, I started developing this neuropathy,
Yes.
peripheral neuropathy in the feet. It progressed. I've been maintaining, I mean, the doctor said exactly what you said, doctor. It is not reversible.
Correct.
I mean, they haven't yet found any medicine to treat peripheral neuropathy. Keep your sugar under control, which I've been doing, doctor. My sugar every day I'm checking every day, and I'm taking regular medication, and I'm going for diabetologist consultation every 6 months. Now, since last year, I have started getting this peripheral neuropathy on my right hand. Right hand.
Okay.
Yes, hand. Hand.
Uh-huh.
I mean, that the right hand is the dominant hand for me. Okay, I'm a right-hander. And that is the hand which I use for working, for eating, everything. But the sensation is lost.
Yes.
Progressively, it has, for the past, say, more than 8-9 months, the sensation was getting lost. But I am persisting in using the hand. I'm using now left hand as well as right hand. Okay. And that is as per the doctor's advice. He said, don't worry about the right hand. I mean, because I'm not able to use my right hand, he said, even the bank fellow said, sir, you're not able to sign. So I asked, will you take my fingerprint? He said, no, you sign with the left hand. We'll agree for that.
Okay,
So
I want to ask you a few questions.
I've been doing it, doctor. But for the past 1.5 months, it is, the loss of sensation is becoming very, acute, chronic. I have been prescribed this medicine, doctor, Mega Neuron PG. I'm taking that medicine because the doctor said this is, I mean, for peripheral neuropathy, this is something good. You take it, he said. And it has to be taken for a long time. He did not specify how long. He said, simply said, you've been taking diabetic medicine for so long, metformin and all that thing. Like this, you keep taking. So I take one tablet in the night, one capsule in the night. But I am fairly safeguarding my foot, doctor, with diabetic footwear, something to wear at home, something to wear outside, all those things I'm taking care. And I have my foot examined by my son. Okay.
Sure. That's very good.
Now and then. But I mean, for no reason, why did I get on my hand this neuropathy, doctor? I mean, I have a lot of friends. We have got a small circle that.
I would like to ask you 1 or 2 questions.
Yes, doctor.
Do you have any weakness of your right hand?
No, sir. This is my.
Are you unable to lift a bucket? Or you unable to
most
lift weights?
useful hand. I use my right hand for everything, all my work.
Okay.
Day to day, hour to hour kind of work, I use my right hand.
Okay. So it is very rare to get a neuropathy in the upper limbs, in the hands.
Yes, doctor.
So this lack of sensation, does it go to your shoulders?
No, doctor. My hand, my fingers, especially, doctor. So that is some. I mean, now I'm not able to do so many things. Say, for example, like wearing a shirt, buttoning. No, because the fingers, they do not have the sensation. I find it so difficult to put on the buttons.
Okay, sir. So I think it is better for you to consult a neurologist to see if you got any nerves that are pinched in your shoulder or in the neck. That could be one problem.
Yes.
Get your thyroid levels checked. So,
I'm taking thyroxine tablet every day, one tablet in the morning on
get your TSH levels checked. Sometimes if your TSH levels are very high and your thyroxine levels are very low, get a fluid buildup in the wrist. So that can lead to weakness of your hands. So please get your endocrinologist, your doctor to prescribe an X-ray of your neck to see if you got any spondylosis in the bones of your neck. Number one, just get your thyroid evaluation done. In case your TSH levels are not according to this one, or your TSH levels are very high, consult.
Hello, Doctor Sir, Madam.
Yeah, I think there's an issue from their side on the internet. Just give a minute, sir. He probably has.
Okay, ma'am.
Just give 2 minutes. They're having internet issue. He'll just connect back.
Okay, madam.
Sorry, there seems to be some issue with their internet connection, but I have Dr. Reddy online.
Okay, doctor. Okay, madam.
So I hope you can hear him. He will continue to answer the questions.
Well, good evening, everybody. I'm very sorry that my Zoom link broke down, and I can talk to you on this. I'm very sorry if I cannot come online.
Yeah, Mr.
Yes, madam.
Have
Yes,
a
madam.
question, or can I move on to the next person? There are a couple of people waiting.
Okay.
Mr. Narendra, you raised your hand for some time. Could you ask your question, sir?
Yeah, I'm Narendra, 66 years old from Bangalore.
Okay.
Thank you, doctor, for your very enlightening talk. Gagar mein sagar, since you understand Hindi, I can put it like that. You have put everything in a nutshell. So for us diabetic patients, I am a diabetic patient since past 20 years, but not a high diabetic person. And I am in control with taking medicines. I just had two questions. My doctor has advised me, my diabetic doctor, to wear, like you said, footwear in the house also. So I am wearing Hawaii chappals. Hawaii chappals, they are open to air. So is it okay? That was one point. Another thing is, another point is regarding varicose veins, which you mentioned in your talk. In case of varicose veins, what is the solution for that? I mean, how to deal with that if because I have some not very protruded or something, but whether I should go for any checkup for that, or because my doctor advised me to wear that socks, long socks which come up to the knees. Is it okay for that to deal with that like that, or I have to do some more? Because this varicose veins is there for me since past 22 years, and I am a diabetic since past 20 years. So these are the two questions I want.
So you asked me two questions. One is the footwear. I would not recommend you to wear the Hawaii chappals at all. Buy the silicone rubber footwear. You can buy it in any of the shops, Bata or Crocs or wherever. Make sure that the top of your foot is covered.
Okay. Silicone, you said? What is that?
One of the trade names is Crocs, CROCS. And you also get other variants with Bata, those kind of people. So it's all just a silicone rubber.
Okay, it should be covered from the top. The front portion of the feet has to be front portion has to be covered. Is it like that?
You might see a lot of kids wearing, children wearing footwear.
Yeah.
Design, but you buy one size loose. Don't make sure it is not tight. One size loose. So those are ideal. Buy two pairs, one indoors, one outdoors. Now,
okay.
Varicose veins are concerned. Diabetes and varicose veins have no relation to each other at all. Get yourself a Doppler scan for your varicose veins. If they are significant, there are a lot of easy measures, what is called as a laser methods. So you can cure those varicose veins within one day. So it's a daycare procedure. That can be done. You can consult your nearby vascular surgeon for the varicose veins.
Thank you,
okay. Thank you.
Next question, Mr. Bhagwan Das has been waiting for some time, so go ahead.
Doctor, normally, I have diabetics for almost 20 years now, and I'm aged about 72. But, last year I had a small spinal injury, and doctors say that it could be due to your osteoporosis. And I'm recommended some other medicines for like Gemtide, etc. Do they interact with my diabetic medicines?
No, they do not interact.
Pardon?
They don't interact with the diabetic medicines.
So I can have safely all these other medicines.
For sure, you can take. Most diabetic medications don't interact, don't have any side effect with other medications. So you can. In any case, you can follow what your physician is.
Okay, that's all, doctor. I just wanted to clarify. But otherwise, my diabetes is almost under control. My regular readings are around less than 200 postprandial. So that is okay, doctor?
If your HbA1c is around 6, that is good enough.
Yeah, it is around 6.25.
That's good enough.
That is okay?
Yeah, very much okay, sir. Very much.
Okay, thank you, doctor.
Thank you.
We have a question from Mr. Uday Kamath. He says, dryness of foot and toes becomes rough, flaky, whitish. Which cream should we apply, or is coconut oil application enough?
Both are good enough. You can either apply a moisturizing cream, a regular moisturizing cream you can buy off the counter, and the coconut cream. Again, the best recommendations to prevent damage to your foot is to wear sport socks. You can actually wear sport socks. On top of the socks, you can wear the covered footwear. So the diabetic foot that we used to get previously was really ugly, unsightly, made of leather, and the minute you wear those footwear outside, people will ask you what's wrong with your feet, and then it's very embarrassing. So the best option would be to wear this newer generation silicone footwear. Actually, the American Diabetic Association is now recommending people to wear this kind of footwear, the silicone rubber footwear, like what you see kids wear, children wear. Those are the best for you right now, simply because they contain soft insoles, gives you plenty of cushioning. The front tops contain pores that allow you to breathe. So that's the best foot care that you can take. And avoid walking barefoot, indoors and outdoors. Even indoors, within our house, we find small dust particles, needles that are lying here and there, dirt and dust particles. We step on that, and that's where the problems start. And going again to places of religion or outdoors, please at least walk in the shade and wear socks, thick socks that will protect you. That's good enough.
Thank you. Is there any other questions?
Hello, madam.
Yes, sir. Go ahead.
I am Ashok Raj.
Good evening, sir. Good evening.
సార్ ఈ ఆనలు అనే దానికి నాకు వస్తున్నాయి సార్ అవి ఈ టో పక్కన ఉన్నటువంటి వేలు కింద వస్తుంటది అది దానికి కారణం తెలియదు కానీ కాస్త మీరు ఏమన్నా నాకు సజెస్ట్ చేస్తారా?
సో దీనికి మేము కార్డ్స్ అంటే చెప్తాము. సింపుల్ హోమ్ రెమెడీస్ చేయండి సార్. అంటే జస్ట్ వారం వాటర్ ఎక్స్గా ఉండే నీళ్ళు సాల్ట్ 4 స్పూన్ సాల్ట్ వేసుకొని మార్నింగ్ 10 minutes ఈవినింగ్ 10 minutes పెట్టుకొని రెగ్యులర్ సోప్ బాత్ సోప్లు బ్రష్ సాఫ్ట్ గా ఉండే బ్రష్ తీసుకొని బాగా బ్రష్ చేస్తే 10 minutes బాగా నొరు రావాలా ఫ్రాక్ రావాలి మారిగా బ్రష్ చేసుకుంటే పోతుంది. దాని మీద మీరు రెగ్యులర్ మాయిశ్చరైజింగ్ క్రీమ్ ఆఫ్ ద కౌంటర్ ఏదైనా వ్యాస్లీన్ అని వేసుకోవచ్చు. కాకపోతే కోకోనట్ ఆయిల్ వేసుకొని సాక్స్ స్పోర్ట్స్ సాక్స్ ఉండే సాక్స్ వేసుకొని ఫుట్వేర్ వేసుకుంటే చాలు.
సరే సార్.
అలా పెద్దగా ఉంటే అది కార్న్స్ కెరటిస్ హానికాలు ఉంటే ఎవరైనా పొడియాట్రిషియన్ దగ్గరికి పోయి దాన్ని మీరు క్లీన్ షార్ప్ ఇన్సిషన్ లో దాన్ని మీరు తీసేయచ్చు.
సరే సార్. థ్యాంక్ యూ సార్.
Thank you.
Dr. Sir, this is Auditor Naveen Chandra here. When we were talking, there was a little bit of problem because of internet, so our talk was disrupted. Is it possible for you to kindly explain for a few minutes? You mentioned me to take a neck. What is the doctor, scan or X-ray? I mentioned about the neuropathy in my hand, in my right hand. Peripheral neuropathy in my right hand, and you said upper limb neuropathy is a bit rare, and you advised me to check the nerve in the neck. What is that test, doctor? Is it a scan or what scan is that?
So I advise you 3 things, sir. One is get an X-ray of your neck.
Okay, doctor.
The bones are actually thinking your nerves that can rule it out. Second,
okay.
Get a thyroid function test. Get your thyroid function test.
Okay, thyroid function test.
The level of your TSH. Thirdly, get a nerve conduction test.
Nerve conduction test. Okay.
Conduction test. It is not an ultrasound. What they do is they put in small probes within the nerves of their hands, and then they stimulate those nerves and see if those nerves are actually conducting impulses or not. So that will give a fair estimate if there is a fluid buildup in your wrist. So then you can go with your doctor. They will be able to see what is to be done. So 3 things you have to do, sir. One is X-ray of your neck, thyroid profile, and your nerve conduction test for your arm, for your hands.
Okay. Thank you. Thank you very much, doctor. Very kind of you. Thank you, sir.
Hello, doctor. Is it okay to get massage done on the legs and feet once a week or something? And should oil be used or the moisturizer should be used?
So if there is an ulcer in the leg, you can go for a very light massage, no heavy massages. And if you've got varicose veins, then again, no massages to be done because it can lead to clot.
No varicose, no ulcer, nothing. Only neuropathy, only loss of touch.
You can use any Ayurvedic oil or any other massage oil, so there is no contraindication. You can definitely go for a massage. Unless you have got redness of your legs, unless you have got wounds in your legs, then you can't do the massage.
Sorry, doctor, I could not clearly understood whether oil is used or not.
You can use oil. You can use any oil.
Okay.
Thanks.
Okay, thank you.
There's a question by Meera who says her legs are getting boil-like things which they become ugly black stains. Doctors say it's caused by age and diabetes. Why do the boils happen?
So the boils happen because of small infections within the skin itself. So, like I told you, a person with diabetes has got very less immunity. Their resistance to infection is very less. So just the bacteria on top of the skin itself can lead to those kind of boils, usually what is called as vector of infection. And then the patchy dark discoloration that we get, the round discoloration we get on the legs and on the feet. Again, because in diabetic patient, the fatty layer below the skin that gets destroyed, that gets disappeared. So the skin becomes dark. So it is called as lipodermatosclerosis. Just an effect of diabetes, just to show that diabetes is probably not under control very much, and better for her to see a diabetologist and get her sugars under control. If she is getting boils frequently and getting pain, fever and redness, better to go for further investigations such as an arterial scan, arterial Doppler scan, and other tests to be done.
I hope that answers your question, ma'am. If you still have a question, please ask. There's another question, doctor. This is by Mr. Raymond Saldana. What is heel bursitis and is it an indication of anything else? How can it be treated?
Bursitis is just a swelling of the soft tissue around your ankle. So most of the time we get bursitis if you're sitting cross-legged on the floor. So we Indians are usually cross-legged sitters. We usually sit on the floor. For nothing, we have a dining table, we have a chair, but we still like to sit on the floor with our legs crossed. So that's where the pressure of the floor occurs on the legs, on an ankle. So that leads to bursitis. So the bursitis, the swelling is very large, unsightly. It can be taken out surgically. Most of the time, it can be left alone, unless it is wounds. There are wounds, there are ulcerations, there is oozing from those bursa. That can be taken. It's a very simple surgery and it heals people. So most of the time bursitis occurs because of that. Because of there is a synovial membrane that covers the ankles. So once you sit cross-legged or strain those ankles, that bursa increases, that grows in size. And please avoid sitting cross-legged if you're sitting cross-legged. And just get a surgeon to see your legs and they'll be able to take it.
Thank you. Ms. Meera can ask a question. How can she prevent her boils from spreading?
So, if the boils are very few and far between, she can apply an ointment called as a teabag ointment for a few days and see. If that's not working, it's better for her to get a consultation with her diabetologist. Maybe her sugars are not under control. Or still, there might be a source of bacteria somewhere within her surroundings. Maybe the seats that she's sitting on, or on the beds that she's on, or on the sofa. Just get them clean properly. Get rid of all the bacteria in your surroundings. Make sure that you change your sheets every few days. Your bed sheets and your pillow covers, because bed sheets and pillow covers are a source of bacteria. They sweat into them, and then they are a source of bacteria. So just get them clean very often. If boils are not going away, please consult your doctor so we can evaluate it.
Thank you, doctor. There's one question. Does diabetic foot happen only with people with long-time diabetes, or can somebody who's recently diagnosed with diabetes get it also?
Generally, we see patients with long-term diabetes with 10 to 15 years of diabetes. Generally, those with poor glycemic control, and also generally with those who have other, this lifestyle habits such as some smoking, alcohol. Alcohol can lead to neuropathy also. Poor diet. So generally, we see these kind of people. I see patients who have got very good glycemic control, who live up to their 90s, who are absolutely hale and hearty. So it's like that. It's usually long-term diabetes. And
just one more question. Does taking vibration on the toes and feet help to increase the blood circulation? What can be done to avoid neuropathy?
Like I told you, once a neuropathy sets in, then it is not reversible, then it is irreversible.
No, if it has not set in yet, what precaution can I take?
Just take a B-complex vitamins regularly, and make sure that your diabetes is under control, HbA1c control. Make sure that your cholesterol is under control, your triglycerides are under control. That should prevent neuropathy by and large.
Okay, but taking vibration doesn't help.
I'm not an expert to talk to you about that. If it doesn't harm you, maybe you can try it. I have no evidence of that. Personally, I have no experience.
Okay, thank you.
There's another question. Sometimes there's a slight depression on legs if pressed. What is it? Is it water retention?
Yes, if you're a diabetic and if you're getting swelling of both the legs, especially more in the evenings. So in the morning when you wake up, you find that the swelling is gone. So that is called as edema. It's simply just a water retention. So it can occur because of multiple factors. One is just a simple protein deficiency itself. Protein metabolism may be altered, you might be losing protein. So just get your protein levels checked. Number one. Number two, look for any ulcers in your legs or any wounds in your legs. Number three, just consult your nephrologist and make them evaluate your kidneys. Make sure that your creatinine and your sodium and potassium levels are normal. So if those are all normal, still you can get swelling of both the legs simply because of the neuropathy itself. Neuropathy itself can lead to swelling of the legs. Please evaluate yourself first, and then if the leg swelling is still there, you can wear class 1 compression stockings. It's the stockings of the leg that should prevent. Keep your leg elevated at night. Even when you're sitting on a sofa or watching TV, keep your legs elevated, put it over a stool, elevate your legs, that will reduce it. And in the meantime, get your heart evaluated, get your kidneys evaluated, and get your protein levels evaluated. If those are not all normal, it's probably neuropathy.
Thank you. How often should a diabetic patient be seeing his diabetologist or endocrinologist?
The recommendation is every 6 months, or if necessary. Get a routine, comprehensive checkup done every year. Eyes, heart, kidneys, foot examination every year for sure. In the meantime, get your endocrinologist to see you every 6 months so that they can adjust your diabetic medication levels. And I'm sure with the seeing you every 6 months, they can pick up early signs of complications if they are coming.
Thank you. Are there any other questions from the audience? So, doctor, is diet very important for a diabetic and to prevent diabetic foot, or is that happens with long-term diabetes, like you said earlier?
Diet and lifestyle modifications are the most important thing other than the medication. If you are a pre-diabetic with the HbA1c of around 6, I think simple diet and lifestyle modification, exercise, diet, walking is good enough. Walking, exercise, and diet should take care of these things. Foot care is very important.
Thank you. Are there any other questions? It's a very informative session. I think all of us learned a lot about how to take care of a diabetic foot today. Thank you for the session and joining us today on behalf of Vikas and all the participants. I would like to thank you once again. And we look forward to having you for more sessions here.
So thank you very much, and thank the audience for being very patient, listening to me and asking me questions. I would like to participate in more sessions, and unfortunately, some Zoom call gave up on me, and hopefully next time we'll have a longer Zoom session. Thank you very much, and good night.
Thank you everyone for joining us on this session. I hope all of you got to learn more about the complications and how to take care of yourself. We request you all to leave a feedback, please, so that we can improve on how we do our sessions and what more can be done in the future. And good evening and have a good day. Thank you everybody once more.